Welcome to my second presentation. This time it will be on the investigation of bleeding disorders with normal initial coagulation workup. And I just want to say two things before I start. First, this presentation will be easier to follow than the first one because there will be less numbers and more explanation. And the second thing is I will try to explain all the abbreviation in order for you to understand and to have the best translation possible. Initial laboratory screening for bleeding disorders vary among providers and centers. But it is a common practice to test simultaneously coagulation factor deficiencies and primary hemostasis disorders. To do that, we will request first a CBC to detect thrombocytopenia, PT, APTT, prothrombin time, activated prothrombin, APTT, activated partial thrombin time, thrombin time and fibrinogen will allow you to detect coagulation factor deficiencies. Von Willebrand disease screen, by definition, is used to detect von Willebrand disease. And finally, when available, light transmission aggregometry associated with the quantification of platelet-dense granules by electronic microscopy allow to diagnose platelet function disorders. Okay. Now, here is a virtual pyramid depicting congenital bleeding disorders according to their prevalence, severity, and diagnostic difficulty. At the top of the pyramid, you have rare congenital bleeding disorders, which often correlates with severe bleedings, but who are relatively easy and straightforward to diagnose. Then, we find progressively more frequent and usually less severe bleeding disorders, but at the same time, those which entail most of the clinical and laboratory challenges. In this category, we have, for example, type 1 von Willebrand disease, mid-platelet function disorders, and mid to moderate coagulation factor deficiency. And finally, at the bottom of the pyramid, there is a large proportion of patients in whom all the classic diagnostic tests are repeatedly within normal range. And so these are the bleeders of undefined cause. So now, if we focus on patients with mid-bleeding disorders, that is to say, after excluding the top of the pyramid, analysis of many clinical studies in patients with mid-bleeding disorders unrelated to thrombocytopenia have shown that after a wide-ranging exploration, between 47 and 69% of patients will remain undiagnosed. So this is a high number. So the first question to ask is, why so much patients remain undiagnosed after the initial coagulation workup? First, so the first reason is that it is sometimes difficult to differentiate physiological from abnormal bleeding. Indeed, bleeding symptoms are frequent in apparently healthy individuals. And so, here are the results of a study that evaluated the frequency of bleeding symptoms of 500 healthy individuals. And you can see that 74% of patients reported at least one bleeding symptom. And the most common were epistaxis, easy bruising, prolonged bleeding after tooth extraction, and menorrhagia. All of these symptoms classically are used to detect patients who can have potentially mid-bleeding disorders. But many healthy individuals also report these symptoms. If we look at this figure, you can see that men reported fewer symptoms than women. But after the exclusion of sex-specific symptoms, that is to say, heavy menses and bleeding during pregnancy, the delivery, and the postpartum period, in fact, there is no difference, and men experience as many symptoms as women. Now, if we analyze individual bleeding symptoms by logistic regression, we can see that easy bruising and venipuncture bruising are more frequent than men than women. We can see that epistaxis is more frequent in African American people than in Caucasians, so me and you. And the last thing is quite logical, but patients who use aspirin will experience more easy bruising and heavy menses. Okay. And now, the first sentence is the most important. The number of non-major bleeding symptoms increases over age, being virtually 0 at birth and 2 or more after age 50. So it means that during the infancy, it's very common to have patients with mid-bleeding disorders and no declared bleeding symptoms. Conversely, it's quite common to have healthy adults after 50 who declare to have had 2 or more symptoms during 2 or more non-major bleeding symptoms during their life. Then, incidence of non-major bleeding symptoms in patients with mid-bleeding disorders is similar with that of patients taking antiplatelet drugs, which is marginally higher than healthy individuals. It's here. And conversely, incidence in patients with moderately severe bleeding disorders parallel that of patients taking VKA, which is this time significantly higher than in healthy individuals. So to sum up this part, in a practical way, diagnosing mid-bleeding disorder from the patient bleeding history alone is tedious because there is a poor sensitivity before age 40, and especially in children, and poor specificity as patients get older. So I insist, I am talking about mid-bleeding disorders, because patients who have severe bleeding symptoms, there is no problem to diagnose them. The second possible explication is the difficulty in diagnosing type 1 von Willebrand disease. Why? Because von Willebrand factor is a marker of inflammation and an acute phase reactance. So, upon an inflammatory trigger, endothelial cells are activated and release massive amounts of von Willebrand factors. Von Willebrand factor levels will follow approximately the same evolution as CRP, C-reactive protein, and the elevation is sometimes greater than 3 times the basal level. in conclusion, inflammation is a common cause of false exclusion of type 1 valve-borne disease. So this, I think most of you already know that there is no problem. Then, there is also the case of pregnant women, because valve-borne factor increase progressively during normal pregnancy, from the first trimester to the last trimester. And in women with type 1 valve-borne disease, it will depend on the basal levels. Women who have basal levels above 30 units per deciliter have a high likelihood to achieve normal levels at the end of pregnancy. That is to say that these women usually will have normal valve-borne factor levels, and so in this kind of women, if we do the testing during the pregnancy, you will falsely exclude type 1 valve-borne disease. Conversely, in women with basal levels below 20 units per deciliter, usually these women do not achieve satisfactory hemostatic levels. Why? Because this category of patients concern mostly women carrying mutations with increased valve-borne factor clearance, such as variant Vicenza. And the mechanism that increase levels during pregnancy is the reduction of valve-borne factor clearance. So if you have a mutation that increases valve-borne factor clearance, there will be no augmentation of valve-borne factor during pregnancy. And finally, valve-borne factor increase with age in normal patients and in those affected by type 1 valve-borne disease, except for variant Vicenza. But why? Why valve-borne factor increase with age and is higher in elderly? There are more and more publications that says that, in fact, this is not the fact that they are older, but this is more due to the fact that older people have more comorbidities associated with an elevation of valve-borne factors. So this is the case especially for hypertension, diabetes mellitus, cancer, and thyroid dysfunction. And valve-borne factor levels increase jointly with the number of these comorbidities. And theoretically, older patients that are very healthy will have the same level as younger people or just a slightly increased valve-borne factor levels. So the takeaway of this part is levels below 30 units per deciliter constitute evidence of valve-borne disease, while convincingly symptomatic patients with normal or elevated valve-borne factor levels almost always require confirmation testing. And the third hypothesis is there is a probable underestimation of the frequency of mid-platelet function disorders. If we look again at this table, we can see that valve-borne disease and platelet function disorders have approximately the same prevalence, which is not related with what laboratories usually do in daily practice, because many laboratories will do valve-borne testing, but few laboratories will do platelet function disorder testing. And so, why there is a probable estimation? Because most patients in this category have a mid dysfunction due to signal transduction defects. And in this category of patients, diagnosis is more difficult and less accurate than those with severe dysfunction, such as Glanzmann thrombocythemia or Bernard-Sully syndrome. And light transmission aggregometry is the gold standard, but the problem is that this method lack of standardization and clear diagnostic criteria. And so, platelet delta storage pool disease is a typical example of underestimated platelet function disorders. Indeed, so these platelet function disorders can happen in syndromic forms, so you will have clinical symptoms that are obvious, but it can also happen isolated. And in this case, the problem is that 1/3 to half of patients will have normal light transmission aggregometry results. So we will miss these patients. And for patients who have positive, so who have abnormal light transmission aggregometry results, abnormalities are often moderate, so sometimes difficult to highlight. You will have an absence of second wave in ATP-induced aggregation at low concentration, and the prolongation of the lag time associated with a decreased max amplitude of collagen-induced aggregation. This is the reason why it is highly recommended to perform at the same time as light transmission aggregometry the quantification of dense granules by electron microscopy using the whole platelet mount technique. And so the takeaway of this part is that it is recommended to investigate von Willebrand disease and platelet function disorders simultaneously when possible, because I know that many laboratories do not have light transmission aggregometry. So if platelet function testing is not available in your institution, start ruling out von Willebrand disease and then refer the patient to a specialized hemostasis laboratory. And I am pretty sure that there is at least one laboratory in Armenia that can do this testing. Okay, so to sum up, we have more than half of patients with mid-bleeding disorder that remain undiagnosed after the initial coagulation workup. It can be due to the difficulty from differentiating physiological from abnormal bleeding. It can be due to the difficulty to diagnose type 1 von Willebrand disease, and it can be due to the probable underestimation of mid-platelet function disorders. So if you eliminated all of this, what's next? On the first slide, I told you that PT, and I told you that prothrombin time, activated partial thrombin time and fibrinogen allow to detect coagulation factor deficiencies. But in fact, this is not 100% true, because as you can see in this figure, these assays do not evaluate the final stage of coagulation, and consequently do not detect abnormalities in factor 13 and the fibrinolytic system. So the next step, if you have a strong suspicion that your patient has a congenital bleeding disorders and all the primary investigations are normal, the next step is to consider additional investigation for factor 13 deficiency. So here are the results of the annual global survey of the World Federation of Hemophilia published in 2023. And you can see that this report revealed 3,311 patients with severe factor 13 deficiencies around the world, And these patients are from 84 countries. Men seems slightly more affected than women. And to give you an idea, to compare the frequency of factor 13 deficiencies with other congenital factor deficiencies, factor 13 deficiency is approximately as frequent, roughly as frequent as fibrinogen, factor 5, and factor 10 deficiencies, and is more frequent than congenital factor 2 deficiencies and congenital combined factor 5 plus factor 8 deficiency. So it's a rare disorder, but not the rarest among the rare bleeding disorders. It is an autosomal recessive disorder. What does it mean? As usual, it means that it is more frequent where consanguineous marriage is common. So in Armenia, so far, in this database, there is only one case. It's impossible to say if it is because in your country there is almost no cases, or unfortunately, some patients maybe are not diagnosed because it's very complicated to diagnose it. But I show you on this slide the pays who have many cases of this disease, and you can see that the country which have the more factor 13 deficiency around the world is Iran. And Iran is close to Armenia. And yesterday, when I was in the taxi to come here, the taxi told me that there are many Armenians that live in Iran, and that there are some Iranians that live in Armenia. So maybe it's important to you to know this disorder. So factor 13. So factor 13 is a tetramer consisting of 2 catalytic A subunits and 2 carrier B subunits. Okay. More than 200 causative variants in the factor 13 gene have been identified, and mostly in the A subunits. Okay. Now, what is important is this part. The number of cases I show you on the previous slide are the number of cases of severe factor 13 deficiency. Severe factor 13 deficiency are characterized by factor levels below 10%, and they are due to homozygous or compound heterozygous defects, mostly in the F13A1 gene. Okay. Now, there are also asymptomatic or mid-factor 13 deficiency with factor levels between 20 and 60%. And there are more and more publications that show that this category of patients is underdiagnosed all over the world. Because when they are symptomatics, they are just slightly symptomatics. So now, factor 13 is responsible for cross-linking fibrinogen to stabilize and strengthen clot formation. This is the reason why factor 13 deficiency is associated with bleeding symptoms. But factor 13 also facilitates wound healing and plays an important role in fetal vitality. So, how to detect this disorder? The most classical symptoms is delayed detachment and bleeding of the umbilical cord. It has been reported in up to 80% of cases, so it's very typical. Then, if you have neonatal intracranial hemorrhage, It's the leading cause of death in this category of patients. So for this clinical presentation, factor 13 testing should be part of the diagnostic workup. And after that, there are other severe bleedings, either spontaneous or after traumatic surgery. And the characteristic of the bleeding that occur after trauma or surgery is that these bleeding are often delayed. They will not happen directly because the first part of the coagulation is to form the clot, and the clot will be formed, but it will happen 20 to 36 hours after the trauma of the surgery, because this is at the time or the clot is fragile, so it will break. And something that is very important, especially for the mid-factor 13 deficiency, is that this is a pathology which is associated with recurrent miscarriage in absence of prophylaxis, even in patients who bleed only a little. And it's very, very common. I am French, so for example, I can give you the example of the French cohort. In the French cohort, almost 100 pregnant women with factor 13 deficiencies without treatment had miscarriage. So it's very, very common. And to conclude with these parts, I will give you the international guidelines and an alternative. International guidelines are always very good, but they are very good for rich countries and rich laboratories, because they always recommend to do everything. So international guidelines recommend a quantitative factor 13 activity assay as first-line screening test. But the problem is, in many countries and many laboratories, it is not feasible in less well-equipped coagulation laboratories. So in this case, you can use clot solubility tests. Theoretically, these tests are seen as unreliable because they only detect severe cases. But if you think about it, severe cases are the most important cases to identify because these are the patients who have life-threatening bleeding symptoms. And the second reason is the advantage of clot solubility tests is that it's easy to perform and inexpensive. So all labs all around the world can do these tests. The only recommendation that I found in the literature is that if you want to perform these tests in your laboratory, you have to perform, in fact, two tests. One with urea and one with acetic acid. Why? Because you can have false positive results in case of hypofibrinogenemia with the urea-based tests, and you can have false positive results in case of high pepsinogen levels in case with the acid-acetic tests. So in your laboratory, if you decide to use the clot solubility tests, the rule is if it is positive, you have two possibilities. Either you send the sample in a reference laboratory to perform the quantitative factor 13 activity assay, or if you have a patient, for example, that comes from Iran, in Iran, as I told you, there are many cases, and consanguineous marriage is common, so most of the patients carry the same mutations. So in this country, they perform country-specific mutation analysis. Okay, and now the last part. If everything is negative, you still have something to do, which can be useful. It's to consider investigation for inherited disorders of fibrinolysis. It's quite rare, but you will see in the last slides that in fact it can be very useful. So, okay. Fibrinolysis is the proteolytic degradation of the fibrin network that results in the release of fibrin degradation product in the blood smear, in the bloodstream. Plasmin is the central protein of this process and is generated from plasminogen on the surface of the fibrin clots or other cell surfaces. And plasminogen is activated into plasmin by either TPA or UPA. Okay. And so this process is regulated by mostly two molecules, PAI1 and alpha-2 antiplasmin. PAI1 will inhibit the activity of UPA and TPA, and alpha-2 antiplasmin directly binds to plasmin to make it ineffective. So it's a complicated biology, but if I said that, it's just to show you the three most common disorders, and in fact the two. I will start by the last one, the Quebec platelet disorders, which is due to an increased level of UPA, but I am pretty sure that you will have no cases in Armenia, because this disorder exists almost exclusively in Canada and in one Canadian family. So this disorder maybe in your country you will not have it. But the two other disorders, you can find them in many countries. So PAI1 deficiency and alpha-2 antiplasmin deficiency. The characteristic of these two disorders, alpha-2 antiplasmin deficiency and PAI1 deficiency, is that they are all characterized by delayed onset bleeding after trauma or surgery and mucocutaneous bleeding, such as menorrhagia and epistaxis. If you are not too tired and you remember what I said on factor 13 deficiency, in fact, this is approximately the same presentation. In addition, for alpha-2 antiplasmin deficiency, intramedullary bleeds in long bones have been described. And you will agree with me that this kind of bleeding is quite rare. So if you have this kind of bleeding, it can be a clue. And in PAI1 deficiency, obstetric complications are very frequent. Miscarriage and preterm birth account for 75% of pregnancy. And to investigate these two disorders, there is no international consensus, but reasonable initial investigation include a globulin clot lysis time and functional assessment of PAI1 and alpha-2 antiplasmin. Okay, I will pass the details and only tell the most important on the last slide of the presentation. So about the globulin clot lysis time, once again, this is a manual method, so theoretically, it can be done in every laboratory. And if this test is positive, so these tests will be positive in case of severe PAI1 deficiency, but it will be typically normal in alpha-2 antiplasmin deficiency. It means that this test is not sufficient if you want to look for disorders of fibrinolysis. So usually, we add functional assessment of plasminogen activator inhibitor 1. Okay. The most important thing here to remember is that you cannot choose you cannot choose the assay that evaluate activity of PAI1 because they were not designed to detect low levels. You have to use antigenic assay. And you have to use a functional assay for alpha-2 antiplasmin deficiency, which will be markedly reduced in case of alpha-2 antiplasmin deficiency, but which can also be moderately reduced in case of other disorders. And for this part of inherited fibrinolysis disorders, maybe for you the most important slide into bracket is this one. You can interpret this slide two ways. So these are results of retrospective studies of patients with bleeding of unknown cause in whom fibrinolytic studies were performed. So mean bleeding disorders without diagnosis. And in this cohort, 39 patients of this patient, 39% of patients had fibrinolytic disorders. So you can interpret these results two ways. Either you can tell yourself, okay, it's quite common, 30% of patients without diagnosis. So you can choose to add fibrinolysis assessment in your lab, which I think can be a good idea for you and for some. But if your hospital really do not have money, you can interpret the problem differently and say people with inherited fibrinolytic disorders are treated successfully with tranexamic acid alone. And this drug is inexpensive. So in fact, if you have a patient without a diagnosis and not enough money to perform tests to evaluate the fibrinolytic system, you can always try to give tranexamic acid to your patients. And that's all for this presentation. Thank you for your attention.